Hello, my name is Vinay Badhwar, and the goal of this series is to help surgeons develop robotic heart programs and focus always on safety and quality. In this series, we hope to share with you our experience in going from the beginning of setup and development and walking through increasing complexity of pathologies and even concomitant surgery, all done through a singular approach, including some very innovative approaches. Now, in this first season, we're going to talk about how to begin, starting with the fundamentals of setup, exposure, opening the left atrium, closing the left atrium, and doing the initial phases of mitral valve surgery. So on behalf of our outstanding team here at West Virginia University, please join us on this journey into robotic heart surgery.
Setting up robotic mitral cases begin with diagnostic cardiac caths being performed in the left femoral or right radial to avoid the right femoral artery. Preoperative CT angiography and TEE on all patients help with preoperative planning. Patients selected without an age restriction necessarily, but at least less than a moderate aortic insufficiency. Femoral cannulation between 17 and 19 French, or per the institution, your anterior purse string approach to start. Distal perfusion catheters are helpful, and bicable venous cannulation, we believe, are essential. Cerebral and right lower extremity oximetry to help guide perfusion, along with vacuum assistance and moderate hypothermia, and the use of a transthoracic cross clamp to begin. Blood marker cardioplegia is our preference and performed antegrade only, but this can be done per each institution, including Del Nido, and full bilateral ventilation when weaning off of bypass are essential steps to avoid any untoward issues. The patient is placed in a supine position and prepared by moving all the way to the edge of the operative table on the right side, placement of a pad underneath the patient, and tucking the arm. This is the overall cannulation strategy and preparation, starting with the SVC cannula. And this can be done through percutaneous access, wire-facilitated cell digger techniques, and utilizing either a 17 Biomedicus or in this case, a 18 Femflex or 20 Femflex cannula. Once this is performed, then a small cut down of 1 centimeter can facilitate exposure on the anterior surface only of the femoral vessels. A distal perfusion catheter can also assist in the overall management of perfusion as shown there. Now, as we look at the transaxillary approach, this is the approach for both the patient positioning as well as the eventual setup of the case.
So now we've talked about how to set up a robotic program. Let's go to the operating room and begin. So we're going to start with marking the patient, positioning, and draping, and then begin the case. Here we are. We've positioned the patient with a bump under the area of the spine so that we have the chest anterior slightly. We've tucked the right arm with the humerus as vertical as possible, and a small pad underneath the right shoulder just to avoid any tension on the right shoulder. So we've also cannulated, much like we've already described. In this particular case, we've done a double stick with the SVC cannula noted here. Now, when we prep and position this for the transaxillary incision, it is the same for mitral as it is for RAVR. So in this case, we're going to identify the key markers. First, the shoulder tip, the edge of the costal margin. And so I'm just going to mark the costal margin, the tip of the shoulder. I'll mark the top of the manubrium and the sternum, as noted here. And now the midclavicular point. And then I'm going to move around and identify that mid-clavicular point to the midpoint here, and then we're going to draw a vertical line in a moment. I usually use my hand and identify. The key thing is the axillary markers, so approximately a hand's mark to here, and that gets to the posterior axillary line. The incision is going to be the quote-unquote transaxillary incision. It will be in the fourth interspace at the level of the anterior axillary line. So in order to do that, we're going to position. Now, this patient is of normal body habitus. This becomes particularly relevant for those that are not of normal body habitus or women. So the same approach is for anyone, but we're going to start now. I usually stick my thumb on the nipple and direct it to the left shoulder tip like that. And I'll make that mark all the way across. This is Faye, our awesome physician assistant. And what we're going to do is she's going to hold that in place. I'm going to stretch and open up the axilla, bring this down, and then mark from here to mark the posterior axillary line. This will become relevant because we're going to prep and position the towels here. We'll also use that with a hemostat. Marking from the xiphoid process to the mid-axilla is always the fourth interspace. Now, what I'm going to do, I'm just going to use my fingers to identify that and identify a spot at the level of the axilla. Now, what's important is we're also identifying the pectoralis major. So we have to be definitely below the pectoralis major. We never go through the pectoralis major or the latissimus dorsi. So in this area where the oblique muscles are present, we're going to identify a small area that would probably be appropriate. So something like that. In fact, that's probably a little too big. I'll probably go a little more posterior, something like that. And then we'll mark our third spot, our third arm, and our fourth arm like this. We'll probably place an LV vent like we do in all cases, the marking point here for the cross clamp, and then right here for our first arm, which is usually a DeBakey. So that's the overall setup. So now when we let go, you can see the incision is much lower, remembering it's going to be approximately this big. And when we prep in a moment, when we put the ioband on, we'll do so to realign the posterior axillary line and the marking point between the mid-clavicle to the costal margin. Now, our typical setup for these cases is to have imaging ahead of time. We have this set up in the operating room, and we have imaging of the groins, particularly looking at the location of the common femoral to make sure that we make the incision high enough. As you will see soon, we make the incision not in the inguinal crease, but slightly above it, so we get direct access to the common femoral. And then we look at the CT scan marked with the liver and all the rib spaces so we can identify exactly the right rib space. Now, what we often do is take a look at the rib spaces in different dimensions as we start to map and plan where we make the skin incision. And also, that's also helpful to mark the anatomy. In this case, the aorta is quite straight, but we will use all the cues we have available through imaging. Okay, so now we've just draped with towels, and usually we put a cummerbund. We've had everything placed. We've exposed the groin. I've stapled along the posterior axillary line, as you can see here, and now we're ready to put the ioband on. And so Faye is going to just pull over these two things and making sure that we have things in place and expose that sort of rectangle. I'm going to place the ioband down, and while Faye is pulling, I'll extend that this way, and we'll stretch the ioband over to make sure that the lines are stable. And therein lies our position, and our incision will be here. So it's moved up by about 1 centimeter, but not much more than that to complete the exposure. But this in itself acts like a bit of a retractor, particularly for those that are of larger size. Okay, so now we've draped, and this is a drape that we commonly use. It's got a plastic thing. This doesn't have to be the one that you would use. These are by Medline, but it allows us to house any kind of material here. Particularly, it becomes very important for when we are using the lines, which you'll see a little later, where we'll bring up the lines on the right side and then put a line through the drape. We'll cut a little hole and that'll be attached to the SVC, and then we'll bring the line up in a U and attach to the IVC. But this is our standard setup, and we've got the patient positioned, and we're about ready to get started.
Now moving to the groin preparation, it's important to identify the inguinal crease and perform the initial 1 centimeter skin incision 1 finger breadth or 1 centimeter or 2 above the inguinal crease. This allows for initial exposure of the soft tissues and truly identifying the common femoral. After initial tangential incision, we utilize soft tissue spreaders to perform the rest of the dissection vertically along the vessels to expose the superficial fascia and the vein as well as the artery, as can be seen. Note that there's very minimal dissection to avoid the issues such as seroma. Purse strings are placed using a 5-0 polypropylene over a slider in both the femoral vein as well as the femoral artery. Now, of course, percutaneous cannulation can be utilized when the program is ready or previous experience dictates. Now, moving to the right transaxillary approach, skin incision is placed approximately 2 centimeters or up to 3 centimeters at the level of the anteraxillary line. Electrocautery is utilized to dissect through the adipose tissue to expose the muscular layer as well as the ribs themselves. As you can see, it's essentially big enough to fit one's index finger. Minor retraction can be utilized, and then subsequent dissection continues onto the rib itself. Obviously, there is no trauma to the ribs, there's no movement or fracturing of the ribs, and minimal retraction of all tissues. Once the chest is entered digitally, completion of the mini thoracotomy incision is performed, and then placement of an extra small, or sometimes extra small, soft tissue retractor. Through the working port, one can then utilize a long tip electrocautery to remove any prepericardial adipose tissue, being very careful to observe the phrenic, which you can see here. Obviously, single lumen ventilation is possible, but double lumen endotracheal intubation makes this quite straightforward. Approximately 4 centimeters anterior to the phrenic nerve, pericardial entry is performed using a Yankauer sucker to help facilitate this in a curvilinear way along the diaphragmatic edge, but avoiding the phrenic obviously is important. This is then reversed and taken up to the anterior surface of the aorta with great care to avoid getting too posterior. Now, once this is done, a small flap is created in this manner to make sure you protect the phrenic nerve, but you essentially are creating a bit of a trap door of the pericardium. Sharp dissection can help navigate the SVC. Once this is done, then 2 to 3 long silk sutures are placed on the edge, and only the edge, of the pericardium. This will become relevant in a moment. Now, what's going to be important is that these be placed and then brought out using a transcutaneous method at the posterior axillary line. This creates this flat trapdoor effect, and then this is snapped to the drapes. Now, just the pericardial retraction alone helps expose the inferior vena cava, and subsequent to that, the oblique sinus. Now, this becomes very important for the performance of mitral surgical cases. The right supramoid vein is identified, and then we move to port placement. These are each performed through a tiny incision just to facilitate the port. This involves the small incisions followed by electrocautery. One of the reasons we do this before heparinization is to minimize perioperative bleeding, and this becomes important as one commences the program. When placing the cross-clamp port, a small umbo tape helps facilitate. Okay, so patient is now systemically heparinized, and Seldinger techniques are utilized to always identify the wire under TE guidance. The vein is accessed first, and in this case a 25 multi-stage venous cannula is inserted with the tip ending at the confluence of the SVC and right atrium, and a slider is used to secure the cannula. Now, attention is directed to the femoral artery. Again, Seldinger techniques. It's very important to always see the wire for maximum safety. This is dilated, and then a cannula is then placed over the wire and then secured. A side limb is attached that we'll use for later for distal perfusion, and the cannula is de-aired and attached to the circuit. By spreading these cannula and attaching them to the skin, it allows for exposure of the distal femoral vessel, which can then be accessed using a Seldinger technique transcutaneously to facilitate a 5 French distal perfusion catheter. This is then connected to that side limb for final preparation. The patient is then prepared for cardiopulmonary bypass, starting with the superior vena cava through vacuum assistance, followed by the inferior vena cava. Now the patient's on full cardiopulmonary bypass, maintaining optimal perfusion. Now when placing the aortic root cannula, which is done through the working incision, the mitral position is more anterior and the aortic is more posterior. In this case, this is a case prepared for an aortic procedure, but nonetheless illustrates the technique. And that under direct vision is placed and then connected to the circuit for delivery of plegia subsequently. A purse string is placed at the level of the right superior pulmonary vein and placed over a slider that is brought through the separate stab incision. And a chest tube is placed through that same stab incision to facilitate placement of the vent. Now we utilize a small technique where we prepare it and create a soft C inferiorly. Now that becomes relevant when trying to place this through a transaxillary approach in an easy way. Volume is loaded, the vein is identified, and then exposed. Once the vein is accessed, you can see that soft C. Once it gets delivered, it automatically flips up. About over 90% of the time, this is a fairly easy way to get this vent in through this small incision. Once that's placed, then a cross clamp is facilitated through the umbilical tape and now positioned to be ready. This is important when we place the cross clamp to make sure it's completely atraumatic. We do a little blunt dissection under the surface of the aorta that permits an atraumatic delivery in an open position of the clamp. Ports are then placed. We use a long port for the number 4 arm and shorts for the rest. The robot is then docked. And the final step is to place the camera, in this case through the working incision, and that now sets up preparation for all future cases.
Okay, now we've done the very beginnings of all of robotic heart surgery. We've cannulated, placed the patient on cardiopulmonary bypass, and docked the robot, and now we're ready to begin. Join us for our next episode where we'll go through the fundamentals of opening the left atrium and closing the left atrium. We'll see you soon.